that's why I'm here, to hope answer some questions, and maybe give you some pointers about what we're doing to try and bridge that gap, so that we can get to the right place. We got a long way to go, don't get me wrong, but I think we're starting to make some changes. Just the conversation that's been going on in this country the last couple of months is important conversation. So I'll stop there and wait for questions.
Perfect. Shavonn, I'm going to go back to you. I'm wondering if you can tell me, so when did you first realize that race, or the fact that you are a Black woman, was something that is being considered when you're getting treatment for your child?
On the first day. I told this story before. The very first time my daughter had an issue with sickle cell disease, she was about 2 months old. And I was really nervous about it. And I usually, when it's in the middle of the night, and I usually take my wedding ring off during the day. And we rushed out of to the hospital, and I didn't have it on. And so now I am not just a Black woman. I'm not just a woman. I'm now a Black woman, and I'm a Black woman with an infant, and in their mind with no husband. And it was our first time in the hospital dealing with sickle cell disease, and I was dismissed. I was nervous, so my conversation wasn't as clear. I didn't know the right questions to ask. I wasn't really able to advocate for her because I was confused. I just had an information session that we had at the Sickle Cell Disease Association 2 or 3 days before that. And all I remember is that if they have a fever of 101 or higher, go to the hospital. So that's really, because I was still overwhelmed from all the information. That's really the information that I remembered from the session. So I didn't remember my wedding ring. I didn't remember, any of these things. And I got there and I was completely dismissed as a person. And it was in the midst of that where I went, this is not okay. I shouldn't have to mention my husband a bunch of times for you to take away, like, at least that, I call them taxes, for at least that tax that I'm paying. And I shouldn't have to debate with you or request to be a part of this conversation when you're talking about my daughter. You shouldn't have rounds without me. You shouldn't make decisions without me. Like but at this time I'm not really, the number of times you have to be in the hospital until you have a kid with a chronic illness is like what, your primary health exam, and how many of us go to all of those? So we really aren't as well versed in ER care, as we are now. And so it was one of those things where I was like, is this right? Like, should I be treated like this? And am I wrong? Like, is this in my head? But I realized, like, no, I'm not. I'm not being treated well. I shouldn't have to tote around the fact that I'm an educated woman. I shouldn't have to give you my resume, right, for you to treat me well. But they're treating me like I don't exist. And regardless of if I do have degrees or don't, I shouldn't have been treated that way. I shouldn't even now think to myself, don't forget your wedding ring. Now I go to the hospital, and while some people can go a lot more comfy than I can, I get dressed a little bit more. I put my earrings on. I make sure I put on my wedding ring. I still have on comfy clothes, but they're not the ones I had back when I was in high school. They're not those comfy clothes, that you wear below the Zoom camera. They're I have to be presentable. My daughter has to be presentable. There are all these things that I have to do, but I realized that the first day.
Yeah, and I literally go in like filthy, dirty clothes half the time to the ER because I wouldn't even think twice about what I wear. I think your conversation about your child's diagnosis, my daughter also has a life-threatening illness, and her female surgeon who found Faith's disease not only had a social worker and a nurse come get my daughter and take her out of the room, she held my arms when she told me my daughter had a disease and was, you know, she was going to help me through it and she was going to get us there. And so when you told your story and I looked more into it and I realized that if this doctor had a baby, she would find out just like you did from the mail that their child has a life-threatening illness. And that is what, like, I think that was what made all the bells go off in my head. Like, she gives this compassionate diagnosis to these families, but wouldn't get the same respect because that's how the sickle cell, or I don't know who does it, but that's how it's done. And newborn testing, the results from newborn testing, that's how it's done. That is what blew my mind, that's the norm.
And there are multiple tests that get done at the newborn screening, right? So the question is, why is if you test positive for sickle cell disease, that's the test that you get a letter for? And that's what's baffling to me, to get that letter. And like you said, in my story, our mail runs on Saturday, but the post office isn't open on Saturday. And so we got the postcard in the mail on a weekend. And when I tell my story in other avenues, I'm honest about the fact that my husband basically had to rock me to sleep every night. I mean, I had to try to think about what this letter was going to say. I was pretty sure it was bad because like I said, I have sunshine and I never got a letter for her. So I knew it had to be something, but the fact that I didn't know what it was, there was nobody who could tell me what it was. It was over the weekend. So I had to go to sleep Saturday, Sunday before I could get to the post office on Monday and find out for myself what her diagnosis was.
Yeah, I'm so sorry. That's so awful. Dr. Denenberg, can you offer any kind of like explanation to why this happens? I don't understand the system. The only answer I could get is that it's really hard to reach families and that's the best way to do it.
So first of all, Shavonn, I got to ask you a question because a friend of mine who is responsible for all of our residents across the system, so very, very accomplished, very educated physician who I've known for a long time, tells a similar story that you tell, that when she's running around after work, after, you know, being a vice president at a hospital, in the grocery store with her 3 kids with her, she gets looked at like she's a single mom trying to run around. And then, like, she just finished as a VP at a very big health system, a $7 billion health system. And so do you feel like when you go in or when you went in, do you feel like people feel like you don't have insurance or you're on Medicaid or you don't, you know, that somehow they're doing you a favor by taking care of you? Do you ever get that sense? And I know it's a hard question. You don't have to answer if you don't want to.
Oh, no. Open book. No, yeah, absolutely. And I think because I am by profession, I work in the social service field. So I've been one to help families in those situations. I've helped families to get Medicaid and things of that nature. I've gone down to DHS with families. And so I've experienced watching what they went through as they were trying to get the services. And I would watch that and I would go, this isn't they shouldn't treat this person this way. And so for me, it was like when I got to the hospital or when I go places, because I forget my ring, sorry, honey, all the time. I know what that looks like because I watched it for the beginning of my professional career. And so for me, it was like, even if that was the case, even if I did not have the space in my professional career that I have, even if I did require Medicaid services, I should still be treated with dignity.
Yep. Well, and that's my point. It doesn't matter.
Yeah.
That's that, and I kind of, it was kind of a loaded question, right? Because that's that implicit bias that some people in this country believe don't exist, and they're just wrong, right? They're just wrong. And until we talk about it, whether you're white or black or Hispanic or green or yellow, or if we don't start talking about it, people are never going to believe it exists.
Mhm.
So
So guys,
to answer your question, I probably would want a little more information, but and Shavonn, you can help me. I don't know how long ago this was, but I suspect the card you got was from the state of Michigan, not from the hospital, right?
The postcard that I received in the mail was from the post office. So it was to inform me that I had a certified
Who'd the letter come from?
Letter, but the letter came from the Sickle Cell Disease Association.
So that's interesting. So the state results typically get released back to the provider that ordered them, and sometimes they get sent to the patient from the state, and it says your state screen had something, contact your doctor, right? So it's not just patients with a positive sickle screen, but the Sickle Cell Association has actually, sounds like they've taken it upon themselves to help get the information out, because they don't want the information to get lost, and so they're acting as middleman, which is maybe good and bad, right? It's bad because they're not the consequences that you're describing. It's good because there's probably kids in the past that have gotten missed for way too long, and it used to be that we believed that you couldn't get sick from sickle cell until you were about a year of age. So missing that for 6 months, probably what we know, that at 2 months you can get really sick from it now. So you don't want to miss anybody. And then some of the things that we test for in the state screen, we got to get a hold of those families within days, because it can make a big deal. So there's probably the Sickle Cell Association stepped in to help out the state and the hospitals to make sure patients don't get missed, and they didn't think about the unintended consequences. It's kind of like we're getting ready to go live with open notes, which means patients can see all their notes as soon as they're signed. So we're trying to teach our physicians, make sure you don't put in the note, Dr. Denenberg has a big old brain tumor, put it in the note, and then don't tell him, and he reads it in the note before you've told him, right? So
the surgeon that I told you about, who told me about my daughter's diagnosis and was so compassionate, and part of the reason that I was so upset about Shavonn's story is Dr. Erica Newman, and she's joining us today from Mott Hospital. And I just wanted to bring her into the conversation because she is a leader at Mott in trying to get this conversation out in the front of things. And she makes me proud for lots of reasons, obviously caring for my child, but it really makes me proud that Mott's having some of these conversations. So Erika, if you don't mind, I want to bring you right into the conversation. Can you tell me what you think the greatest threat that our nation has in being able to achieve equality in healthcare?
Hi, thank you so much, Marianne, and everyone. I'm sorry I was a couple minutes late. I think this is a great question, and I love talking about this topic because I think that our institutions can really drive change. And so for us, for example, I push Mott and Michigan as an institution to try and understand these problems. There are a lot of barriers, I think, to equity and health equity. And I think a lot of the root causes have to do with poverty and poverty along racial lines. And so, for generations, people, particularly people of color, have been marginalized by our institutions. And so, the criminal justice system, for example, our educational systems where, Black neighborhoods have huge educational gaps compared to white neighborhoods. And, how this relates to healthcare is that, poor neighborhoods have lower life expectancy. And so how do we reckon that by, our, missions within our organizations is really what I think one of the solutions would be. And so one, we have to just be able to admit that these inequities exist within, and that they're embedded into our systems and they're part of our structures. And so admitting that they exist, and then implementing tactics and strategies to try and break down and dismantle those inequities.
Do you think the healthcare systems are willing to admit that the inequities are there? Like, I am such a proud mom. When I hear stories that are negative about Mott, it like crushes me. It makes me sad. I think, oh, not my Mott. But like, my question is like, I know that you're bringing these conversations to the forefront, and some of our Mott moms that are here are pushing Mott to make sure this is a conversation that we're having specifically at Mott Hospital. But do you think the hospitals, Matthew Denenberg is from DeVos, and he's even saying, like, obviously this is something we need to be talking about, but are the leaders in the institution willing to have this conversation?
Yeah, I think, listen, none of this is intentional. And so when we talk about bias, it's mostly implicit, so it's implicit bias. So when people do and say things, as an example, I don't think that these are intentional most times. Now there is overt, racism and explicit things, but I think the majority of times that none of this is intentional. And so I don't think that our goal is to be punitive or to be inflammatory around these things. And the way that we're really approaching this is that we want to learn more, and we're educating ourselves, and we're engaging in the community and partnering. And I think by doing that, the leadership is ready. A lot of this is, some of these problems are deeply embedded in our society even. And so it's one thing to talk about how people are treated when they come. And so that's part of our culture. And we're looking at that too, making sure that our culture, when patients and families are inside our walls, that they are not subject to bias, racism, discrimination. And so, that's one aspect. But the other aspect is, what's our responsibility to the community and to communities that have been impoverished and oppressed for 400 years in America, Black communities. And, with no investment, no hope for upward economic mobility. And so when our institutions, including the healthcare system, can own that and say, what's my role in that? What's my role in, community wealth building, so that people that have traditionally been oppressed can have move out of that? Because that's really what we're talking about. Like if Black people in America have upward economic mobility, then this racism thing, may not matter as much on a, global level. And so we're pushing ourselves. We're recently joining this becoming an anchor network, an anchor institution. And so the anchor institution, I don't know if anyone has ever heard of those, but what it means is that it's really a commitment to the community and the neighborhood that the institution makes. And for us, it's going to be three things. It's going to be committing to local hiring and recruitment and human resources, and developing those within our local community in neighborhoods that are impoverished. And then the second thing is procurement and purchasing. And so preferentially utilizing minority and women-owned businesses for purchasing and procurement. And then the third thing is local and socially conscious investing. And so the institution is going to commit to doing that and anchoring our communities and contributing to building wealth in the local communities. Because I think ultimately, if we're ever going to shift the atmosphere on racial inequity, then we have to begin to understand the root of some of these problems, and the root cause is really poverty.
Mary Ann, I just want to add to that, and I think one of the things that we struggle with as health systems is it doesn't have to be the Black members of the team that are championing this. In fact, it's not going to be successful unless everybody's participating. So, it may not seem like a big deal, but if you think about what happened in this last 6 months, the governor of Michigan mandated that healthcare providers do implicit bias training as part of their licensing in the state of Michigan, something that we initiated at our hospital system, about a month before she did that, recognizing that it's not going to solve the problem, but if you don't start talking about it and you don't start having your team members talking about it, we aren't going to get to those places that Erica is suggesting we need to get to. In addition, we're doing the same anchoring. We're actually investing in housing in addition to some of those other things for the community. And then lastly, I want to tie this back to North Star just for kind of fun. One of the things that Erica mentioned that is critical is one of the things that we're doing, for example, is we are really making an effort to hire for diversity, so that those numbers I gave you at the beginning start to change. Our percentages of people that are on the team. We instituted the Rooney Rule, which comes from the Rooney family, which had a big deal to do with camp in the beginning. And the Rooney Rule mandates that any hiring we do at manager above requires in-person, team-based hiring, and a certain percentage of minorities have to be included in the pool. Understanding that we're not going to necessarily hire a person that's not qualified, but unless we start doing some of those things, the anchoring stuff, the implicit bias training, I'm a little bit put back because we have a president that says implicit bias doesn't exist. This isn't a political statement, but if we don't start talking about it and we don't start doing something about it, we're not going to make the kind of changes we need to make. Erica, by the way, Dana Tellum came and lectured and talked to us in Grand Rapids right before the COVID pandemic started, and you got a really good team there working on this with you. So
yeah, she's definitely she's my sister in this work. So
all right, guys, I have to ask some questions that I think are kind of hard. One of our moms who is got her screen off, who I understand, but told us about an experience where she got the police called on her because she raised her voice, and she got kicked out of a hospital. And I've known this mom a long time, and I talked a little more to her about that conversation, and I raised my voice probably more than I should at the hospital. I'm polite about it, but I definitely raised my voice, and I said, I have to get details. I have to know exactly, I mean, I know I've known this mom for a few years now. So I said, I have to hear exactly how you said it. And I'm thinking I could have had the police called on me if I was in her shoes. And that's scary to me that she's scared to go to certain hospitals because she's afraid she's going to maybe be treated or profiled. So both Matthew and Jessica, because I have another question for Erica, what can parents do if they feel like they're being discriminated against, if they feel like the actions that are being taken have something to do with who they are rather than what they're actually doing?
This is a hard question for me to answer, not because I don't think I'm capable or willing to talk about it, but I think one of the problems is that the implicit bias and some of the issues that we've been talking about are so ingrained that it's easy for me to say she should ask to talk to the patient advocate, she should ask to talk to the physician in charge, she should ask to talk to the social worker. I mean, all those things sound easy and lovely and adequate, but they're not, right? Because once that decision's been made in someone's mind to look at that person the wrong way, it starts a cascade of events. I can only imagine how they got to that point where the police were called, and there's so many things that are ingrained in that hospital's way of doing things that ball was rolling probably way too fast to stop in the moment. We have to get back to the root of where this is so that doesn't happen anymore. And so there's no real good answer except for, raise your hand, ask to talk to somebody in charge. And even then the police are there. So that's going to be hard to do, but it's necessary. And then talk about it afterwards, right? Call and try and talk to, once it's happened, because we need to know, we need to try and fix it for the future. And again, there's so many things wrong with those stories that we hear, that there's no easy fix in the moment. I wish
Yeah.
there was.
This mom lives somewhere where I travel with my daughter, and I think, oh my gosh, I got to get the name of that hospital, because I can see myself, you know, they come in to do something with Faith and I don't like the way they're touching her. I can just see that sometimes when we're tired, we, you know, we react quickly, and I can just see myself getting in trouble. And like Faith would be horrified and terrified if I got kicked out of a hospital room. Jess, what kind of strategies would you suggest?
Yeah, I think similar to what Matthew was saying, I think talking about it afterwards and helping to communicate through, you know, the situation. I think also finding your people, especially for families who are chronically inpatient, finding those advocates that you know, that you trust. It could be a social worker, a child life specialist, a nurse, a host, anyone, but those people that you connect with, that you talk to regularly, those are the people that are going to be able to help you through some of those situations, hopefully, and help to navigate some of that stuff that's a little bit more high stress, or you know, sometimes even translate some of the things that you're trying to say in the heat of the moment when your anxiety level is sky high. So I think finding and identifying who those people are that you know you can contact, that will always kind of come to your aid. I remember when I worked at Mott specifically, the transition from pediatric care to adult care for our sickle cell patients was horrendous, because they go from having this wonderful team of great advocates that they know and they've grown up with, to moving into an adult world that they don't know anyone, and they know not long checking in with them about school or about work or self-care. And so all these things that were missing, and a lot of that has changed and is continuously changing. But when our young adults would come into the ER and look fine because they don't look sick, and they ask for pain meds because they know what their body needs because they've been doing this for so long, the first reaction is usually, okay, well, I think this patient might be drug seeking, or you know, they're a routine visitor. So we always add or let them know, you need to call. Here are your people when you're at the hospital. Here are the people that are here on which days of the week. Call one of us so we can come down and help advocate for you, to help make sure you get what you need. If you're there by yourself, if your parent's not with you, we're going to be able to be there and help to support you through that. So I think making sure you can identify who those people are, especially if you're spending a lot of time in that hospital setting or visiting outpatient or emergency services often.
Yeah, for those of you who were in the talk earlier, you're quarterback.
So here's the part that's hard for me as a healthcare provider. We are that person's people. You shouldn't have to call somebody else. We are your providers. And when we sign up to be physicians, I've taken care of patients. I'm Jewish, right? And I've taken care of physicians or patients who had swastikas tattooed across their chest. Didn't matter to me. So the fact that they have to call their people is really hard to understand.
Yeah, that's sad. Dr. Newman, a question for you. This week I had a conversation with Shavonn. That's Shavonn, actually. And she was telling me about an experience that she had where she knew she wasn't receiving the care for her child that she deserved. She said she had to be careful about how she sounded because she didn't want to just sound like an angry Black woman, because her child would never get the help she needed. And I'm paraphrasing, Shavonn, I'm sorry if I'm not doing it perfectly. My question for you is twofold. Is this an actual reality for parents? Like, I mean, you know me, I get heated all the time with Faith. So like her saying that to me shook me, that she has to worry about people thinking she's an angry Black woman. And then, so is this a reality for our parents? Do they need to contain their emotions for fear that their child will not be treated properly? And then as a follow-up, what can parents do to protect their patients' rights in that case?
So unfortunately, I think that what Shavonn is describing is very common, and it's not just in, healthcare. It's in all spaces where, Black women. I mean, I don't. This is not a political thing, but if you watch the debate last night, people were complaining that the vice president candidate on the Democratic side was composing herself and not being as forthright for this fear that she would come off as an angry Black woman. So I think that is I think that's a reality. When my advice for parents, though, as we're navigating this and trying to advocate for our children, is one tactic that I think really works is to stay curious and keep asking questions for clarity to the providers, even when we're sensing that there may be some bias or discriminatory behavior, or you're being treated differently. Keep engaging and asking questions very directly, and help navigate what and how and why decisions are being made and how you're being treated. And I mean, I think it's really, and I've watched parents do that, and I think it's really helpful for a number of reasons. Sometimes, when we're engaging more and digging a little bit more below the surface into why providers are making the decisions that they're making, maybe it has nothing to do with race or gender or the other things that we're suspecting, and maybe there is something else at the root of what they're doing and saying. So that's one. But then maybe you're right, and maybe your questioning and going deeper will cause that provider to check themselves and become more aware and more self-aware of what they're saying and how they're saying it. And the other thing is we have to start calling this out. And it is perfectly I think within the realm of where we are socially today in America for someone to say, I am concerned that the reason that you are saying that or treating me, or I'm being treated this way, is because of the color of my skin, and I'd like to talk that through with you. And I think we have to remove the emotion from some of this if we're ever going to make progress, and be able to talk about race and race relations, particularly when it has to do with the health of our children, and not be emotional about it, and just say, listen, I'm feeling this way and I want to talk it through, because if this is true, we may need to, and always feel free to change providers. I mean, Marianne will call me anytime. I gave her my cell phone number, we text, and you can always say, I would request that we can change doctors. I mean, you can always do that. But the truth of the matter is we got to start talking about this and calling it out, because doctors are not perfect, they're human. Nurses are not perfect, they're human. And so if someone, I may do or say something, but I hope that my patients or their families would say, listen, when you said that, here's what it meant to me. Here's how this felt. This was my perception. And start really walking this journey together. I mean, that's the only way that, we're going to be able to make progress. It's a race relations. This has been brought to the forefront, this racial reckoning that's happening. And so I think it is an opportunity for us to make some really good forward movement together. I mean, we saw white people and Black people out in those streets when George Floyd got murdered, and when Ahmaud Arbery got murdered. And so I think America is ready for this. We're ready to talk about it. And so just start, I have removed emotion now when I talk about race, and I say, look, this was said and this is how this felt. Let's talk this through. And if people are not ready to do that, then, that's not, I don't take that personal, because in order for us to make progress, we have to be able to talk about these things.
To remove emotion, it must take a lot of strength, though, because I can tell you, I get emotional talking about Shavonn and talking about the fact that you could be discriminated against because you're Black and you're my daughter, you saved my daughter's life. So like, I can't imagine being able to remove emotion from it. It seems so emotional.
I don't want to get into this, because this is really about the camp and the kids that we take care of. But there's also, we struggle, and we're working on the reverse piece of this too, right? We work on the racial inequity in our providers too, the way they're treated by patients. And again, this is about the patients, but it's a double whammy for healthcare, because we also get the opposite, where somebody says, I don't want you taking care of me because you're Black or you're Hispanic or you're Muslim or you're Jewish. And it's especially true when you're in the emergency department. Like, well, you got a choice. I can take care of you, or you can let your heart attack progress until the point where. So I just want to bring up that this is something that especially some providers have to wrestle with this both ways, right? It's a particularly difficult for them.
Mind blowing to me that happens, that's mind blowing to me. Like, I can't imagine, like.
Marianne, this happened to one of our interns about 3 weeks ago. On a vascular surgery service, a Black woman. She walked in and he didn't want her to take care of him. And he, after 24 to 48 hours of her being on the service, he flat out said, he said, I'm a racist and here's why. And he started to lay out reasons why he was a racist. He had served time in prison, and there were a lot of Black people in there, and they weren't very kind to him. And, something that happened with his daughter and a Black man. And he flat out said he did not want her taking care of him. So we had to navigate that, in our system for a couple. It was very complex, because one, he was a patient within our system. So we had to figure out somebody has to take care of this man. And then, you have this intern who has been a doctor for 2 weeks, who is trying to learn and, has this experience, this mid-COVID racial unrest. And so we wrote out a patient bias protocol and put steps in place to be able to protect the patient as well as the learner. But, this is the times that we're living in now.
That's frightening. Okay, so we don't have much more time, but I want to know what we as parents can do, because I am an advocate and I have the staff of North Star Reach here, and our sickle cell population is the heart of this place. I tell you, like, those campers there's something about the population. So tell me, what can we do? What can North Star Reach do? Like, what can we do? How can we be a part of the change that needs to happen?
I'm going to say something that may get me in trouble and get me kicked off the board, but I'll take a chance. This isn't only about sickle cell and our sickle cell camp. And I know that's the sort of camp and the population that's, raised some issues because of the complexity of the camp. So I'm not naive to what sickle cell camp is and why. I mean, I trained in Detroit, New York, so I see that. But it's about us having these conversations openly with our staff and with our parents, and quite frankly, with some of our older kids when they're ready. So, if we're not willing to talk about this stuff, it doesn't really matter whether it's sickle cell camp or epilepsy camp or diabetes camp or whatever other camp we have. These issues, it's just more prevalent in sickle cell camp because it's the difference between our staff and the patient population is so obvious. But this is something we have to talk about and be willing to work at, and maybe even definitely increase the diversity of our team, and at least the conversation around diversity.
Yeah, well, and I know from a parent perspective, I'm the HR person here at North Star Reach now. I want to be here for this population of people that is being so, like hearing one of my sickle cell moms got kicked out of a hospital and now is afraid to go back to that hospital, like makes me want to cry. And I want to make sure we are part of the solution. Dr. Newman, can you tell us what MOT's doing specifically?
So I love this. Thank you for this part, because I do have this little thing that I've been using, and I call it sort of the L's of how we can solve this. And so what are we really talking about is leveraging our differences, right? Our differences make us stronger, better. There's a lot of data now that the more diverse and representative our teams are, that we're higher performing. And really diversity is required. It's our obligation to be diverse, because that's going to make us better, and it's a metric of excellence. And so how do we do that? So leverage our differences. One is learn more. Learn more. Just keep educating, learning about the diseases and the conditions that we're taking care of, and that our families and our kids have. Learn more about how to have these conversations, learn more about some of the root causes of inequity and disparities. So learn more. Secondly is lower bias. And so, for example, in our Department of Surgery, we all were trained on how to lower the influence of implicit bias in the way that we recruit faculty and residents into our programs. And so lower bias in everything we do. How do we decrease the influence of bias, and how we, take care of our patients and build out new clinics and new programs. And so learn more, lower bias. The next one is language matters. And so the words that we say and how we say them, even the word diversity, it means so many different things to so many different people. We probably all would give a different definition if we had to write it out right now. And so I really have been shying away from that. I've been using words like representation and differences and identity, but language definitely matters. And so we will learn more about what language is and what language really means and how it impacts all of us, and so just understanding language. The next one is, for us, we've said we're going to try and level the pipeline. And so level the pipeline, and that means, the people that we're bringing in to work and recruit into our spaces, and not having homogeneous spaces. And that goes always, you would, if you're in a boardroom and it's homogeneous, if it's all Black or white people, that's not the best team. And so really leveling the pipeline so that all of our spaces can be representative. And then the last one, this is the one, as I'm like easing into some of these leadership roles, is just lead with love. And if we start having love kind of lead us through some of these really tough problems, sometimes we think love stops short of when we go into the four walls of where we work in our professional lives, but it doesn't. I don't think it does. And if we bring that in with us, then, I think that's what do you guys think about that? The L's. I didn't name them yet, but. Yeah.
Coach, can you do a song for us?
Including all of the L's.
All the L's. You got to get by next summer, you got to have an L song for us. We'll name it the Newman song.
I've already listened to those L's, and I'm going to lay a little great track for you.
Guys, I want to thank you so much for being here today. This conversation, this is the very beginning of this conversation. The panelists who came today, I appreciate you. I know this is not always the easiest thing to talk about, but it's got to be something we're talking about all the time. And I appreciate you taking the time out of your busy days. I know both of our doctors are always very busy. So very grateful for you. In the next session, we have a doctor who was just published in the New England Journal of Medicine and talks about, you know what? I think he even used racism, which I think is awesome. And he's going to talk to us about, oh, Dr. McCann, you're here. I just saw you. We're gonna take like a couple minute break, but he's gonna do a presentation for us. And so I just want to thank you all for being a part of this.
Thanks, everybody.
Thank you.
Thank you.
Thank you.